So from the examination point of view, two types of evaluation is important. One is the clinical evaluation and next is the radiological evaluation, which you should be very clear in and how it has to be done. So let's start with the clinical evaluation. In the clinical evaluation, we start with history. So it's a routine history which we take, but what is given importance here is the age. So, you know, in the first few decades, the benign tumors are more common. After 40, first differential diagnosis should always be a metastasis from elsewhere or myeloma rather than primary bone tumors. And what is important is most of the primary bone tumors are common in the first few decades, except for chondrosarcoma. Chondrosarcoma occurs in an elderly age group. And sometimes osteosarcoma have a bimodal age group or secondary osteosarcomas arising from irradiated area or a Paget's disease can occur in elderly age group. Next is sex. Giant cell tumor, parosteal osteosarcoma and ABC have a slight female predilection, but most of the bone tumors have equal or more male predilection when compared to women. And family history is important because there are few hereditary genetic mutations which can be passed on to the children. One is Leaf-Romini, which is P53 mutation, retinoblastoma, Rothman-Thompson, and Bloom and Werner's. These are all hereditary osteosarcomas. For chondrosarcoma, there is multiple hereditary exostosis, which is autosomal dominant, you know, and they have higher chance of converting into a secondary chondrosarcoma. Next is race. May not be very important in our thing, but what you should know is Ewing sarcoma is rare in Africans. GCT is very common in Asians, and chordoma is common in the Caucasian group. And for socioeconomic status, usually people of lower socioeconomic status, they present late because of financial issues or they don't take care of themselves. So when they present with large tumors and advanced stage, and it is very difficult to treat at that stage. And also what is important in history is whether patient has received any prior radiation therapy. That is radiation-induced sarcoma is also a possibility. Then when you see presenting complaints, there are only three major presenting complaints: pain, mass, or a pathological fracture. Next slide. Next slide. Yeah. So when you see pain or mass, we'll talk about pain first. The pain which does not go even with even more than 2 weeks. These are all red flag signs to be evaluated. And the pain, it is disproportionate to the swelling which is visible because of first the pain is mechanical and then the pain is because of production of all these cytokines and prostaglandins. And the swelling, usually it is sudden in onset, short duration and rapid progression for aggressive tumors. For benign tumors, it might not hold true. Then you can see the various types of swellings which we see in clinical practice. You can see the huge amount of swelling. And what is important is half of our patients who come to the OPD would have undergone some unplanned procedure elsewhere. So to note the scars and any sinuses or any drain tracts also is very important, which we have to observe. And fracture following trivial trauma, you know. Next slide. You can see these are all mostly horizontal fractures, and definitely you can pick up some lesion in them. And they occur following a trivial trauma. And if you inquire, patient will definitely give a history of pain prior to the fracture. And constitutional symptoms are seen in few of the malignant cases, most commonly in Ewing sarcoma, like fever, loss of weight, loss of appetite, and loss of sleep. And sometimes, very rarely, it could be because of incidental findings. No patient goes for an ankle twist or a fall and get an X-ray, and you rarely pick up these incidental lesions, which are probably not the cause of the pain. You can see a non-ossifying fibroma here. So on examination, on inspection, you have to see the attitude. The attitude usually, because of the large tumors or the muscle spasm, you can specify whatever the attitude is there. And on inspection, always compare with the opposite side. You should look for muscle wasting. You should always take the circumference of the lesion, because most of these always take the circumference of the lesion. And talk about the swelling, whether it is well demarcated or diffuse, and the routine things, size, extent. And note down the skin, scars, and wound, like I've already told. Also, when the patient has undergone a procedure elsewhere, it is important to note if they have put drains, one or two, and locate the site of drains before you start treatment, because all that has to be excised during a definitive surgery. Next. And the entire limb is examined. You have to look for engorged veins, edema, enlarged lymph nodes, very, very important. In lower limb, you look for popliteal and groin, the inguinal lymph nodes, and for upper limb, you look for epitrochlear and axillary lymph nodes. Look for any joint effusion. It could be reactive or it could be because of a path fracture, interarticular path fracture. Any limb length discrepancy and muscle wasting also has to be noted. On palpation, you confirm the inspectory findings and elicit tenderness. Look for the consistency, the surface, the edges. And look for mobility. Most of these bone tumors, almost all, they are immobile. And other things might not be very important, which you see for swelling of soft tissue tumors. Next. And main thing is movements. Again, you should be very gentle because they'll be painful and there will be a risk of pathological fracture. It should be gentle. You see for active and passive joints, passive movements, and look for adjacent joints. And you take measurements from fixed bony prominences. And other important points to note are the vascular examination. Look for distal pulses, neurological status, because it could compress on the nerves. Look for other joints and lymph nodes, as already told. So once you see a patient in the clinic and you're suspecting a bone tumor, the next step is to ask for an X-ray. So these are the common location of tumors based on the age group. So you should know what are common in the epiphysis. Epiphysis, 3 tumors are very common. Giant cell tumor, your ABC, and metaphysis is your routine tumors like osteosarcoma, which is very common, metaphyseal. In diaphysis, you talk about Ewing sarcoma, lymphoma, fibrous dysplasia, eosinophilic granuloma. All this comes in the diaphysis. And when you're asking for X-ray, you ask for the entire bone and 2 views. And when you're reading an X-ray, you say it is where the lesion is located, epiphysis, metaphysis, diaphysis, and then you start describing the lesion. Next slide. So when you're describing the lesion, what we have to see is what the tumor is doing to the bone and what the bone is doing to the tumor. What the tumor is doing to the bone is whether it is light, what is the type of the lesion, lytic, sclerotic, or mixed type, and where is it located on the longitudinal plane as well as the transverse plane. And what is the tumor producing, the matrix, and the type of destruction, and whether the cortex is destroyed, and whether it has any extra osseous component or not. And what the bone is doing to the tumor will be the line of demarcation, periosteal reaction, and bone expansion and remodeling. So let's see each points here. Say I've shown 3 X-rays. On the top right is the lytic lesion, top bottom is a sclerotic lesion, and lower left is the mixed lytic and sclerotic lesion. Next slide. And on the longitudinal plane, you say whether it is located in the epiphysis, metaphysis, or in the diaphysis. And next, in the transverse plane, you say whether it is a surface tumor located on the periosteum or an intracortical lesion, most commonly like adamantinoma, non-ossifying fibromas, or a intramedullary lesion. Next slide. Or a intramedullary lesion. If it's an intramedullary lesion, you say whether it is a central lesion or a eccentric lesion. Simple bone cysts are usually central and ABCs are eccentric. Yeah. Next. So you define on a transverse plane whether it is a surface lesion, cortical lesion, central, eccentric, or central. And next, you describe the matrix. The chondrite matrix is typically called as arcs and rings or stippled calcification, popcorn-like calcification. And the osteoid matrix is called as fluffy cloud-like calcification. Next. So you can see the first one is the osteoid, second one is the chondroid, and third one is the ground glass appearance, which is seen in fibrous stroma. Next. Next, you describe a lesion. When it is a lytic lesion, you call it either a geographic, moth-eaten, or permeative. So what is a geographic lesion? A geographic lesion is a single large lytic lesion. When it has multiple holes, which are smaller, which are 5 to 10 mm, then you call it as moth-eaten. And permeative is when there are multiple lesions, but they are less than 5 mm, then you call it permeative. So this geographic lesion, which is a single large, more than 1 centimeter lytic lesion, can be further divided into A, B, C, which is geographic 1A will be a sclerotic rim, 1B will be without a sclerotic rim, and 1C will be wide zone of transition. We will not be able to demarcate between the normal bone and the pathological bone. Next slide. So that is known as zone of transition. So zone of transition is the area between the normal bone and the tumor and the lesion. So when you can take a pen and draw the lesion line of demarcation around the tumor, it is narrow zone of transition, and it is more common in low growing, slow growing tumors. When you cannot draw a line between the normal and the tumor bone, then probably it is aggressive tumor, and you say the zone of transition is wide. And periosteal reaction, all these types, the various types of periosteal reaction are there. We'll start from the right side. There is no periosteal reaction there. There's only expansion of the bone. So that means the tumor is not growing at a rapid rate, and the host body has time to form bone. It's just getting expanded, and the periosteum is laying new bone. So it is probably a slow growing tumor, and there is no periosteal reaction. Second one you can see is a solid periosteal reaction, probably long term, benign probably. Next one you can see onion skin, onion peeling with the wide zone of transition. It's probably malignant. You can see Codman's and sunburst in these two. And the Codman is because of periosteal elevation, and sunburst calcification is because of calcification along the Sharpie's fibers. So this all will tell it is more malignant. And whenever there is cortical destruction and extraosseous component, it is more in favor of aggressive tumor. Here you can see the anterior cortex destroyed, and you can see a huge extraosseous mass in this. So probably pointing towards more malignant lesion. And this is bone expansion, which you see in a without periosteal reaction in a benign lesion, and this is a ABC of a distal humerus. Once the X-ray is done, you reach a diagnosis. You can know whether it is benign or malignant. Probably, likely. It can change also. The next step will be to ask for an MRI. On MRI, why do you do an MRI is you should be sure MRI doesn't give us a diagnosis. MRI is done to see the extent of the tumor. So you see the extent, both the intramedullary extent as well as the extraosseous extent. You look for the neurovascular involvement, which is very important when planning surgery. You can plan a biopsy because MRI will tell us where necrotic component or a cystic component is there. You can avoid those areas and target solid components, and you can plan your margins and reconstruction on the MRI. Next slide. And always whenever you are asking for MRI, you ask for a full length MRI of the entire bone. Because outside, usually when we ask for MRI knee, let's say a common tumor is a distal femur tumor, we ask MRI knee and they do only MRI knee, they don't cover the entire limb. One, skipments are gone. And usually this lesion is longer than the knee, and the entire lesion is not covered. So always whenever you're giving a prescription, ask for a full length of the bone and not only the joint. And having metal is not a contraindication to do an MRI. You can ask for a mass MRI, which is metal artifact reduction software MRI. And be very sure MRI is not done for the diagnosis. And do not plan a definitive MRI report. So you always ask for an entire MRI, see, because there are skip lesions and scale is included for measurements so that you can plan our bone resection margins. These are skip lesions which you can see. So contrast MRI will be better because it will tell us which are necrotic areas and cystic areas, and we can target solid areas for biopsy. Next slide. Biopsy. And why is biopsy very important in musculoskeletal oncology? Because we always consider the biopsy tract to be potentially contaminated and it must be removed during the definitive surgery. So biopsy is done after imaging because the hematoma and inflammation can alter interpretation of the studies. And there are a few touch me not lesions, like I told, see, MRI is not for diagnosis, but there are a few exceptions. See, you can see osteoid osteoma, osteochondroma. Next slide. Next slide. Enchondromas, simple bone cysts. Yeah, simple bone cysts, fibrous dysplasia. All these can be almost accurately diagnosed with an MRI by an experienced musculoskeletal radiologist. A biopsy can be avoided in these patients. Next slide. And target site, like I told, you can avoid the necrotic and cystic areas. Next slide. And to plan anatomic route. And the biopsy which we should do is a core needle biopsy. Don't go with the FNAC. Try to avoid incisional biopsies. There is no role of FNAC in primary bone tumors. However, in cases of recurrence or when you feel there is metastatic carcinomas or to prove enlarged node is there, you can do FNAC to prove the malignancy there. But otherwise, there is no role of FNAC because these bone tumors are heterogeneous. You know, some areas might be low grade, some areas might be high grade. And FNAC, you get only the cells, you don't get the matrix, the tissue which is produced. So very rarely people can give a definitive diagnosis on FNAC. Next slide. So core needle biopsy should be the stages are it has low risk of contamination, minimally invasive, can be done image guided in OPD, and it is cost effective. The disadvantages are only a small area sampled, reliable grading may not be possible, and you need an experienced pathologist to give a accurate report. So whenever doing a core needle biopsy, the principles are it should be placed along the line of future incision. A shortest anatomic route may not always be the best route. Don't violate anatomic compartments or joints, and you take adequate course. And open biopsy is done at our institute. We do an open biopsy only if core needle biopsy has failed to give a report. We have done at least 2 times a core needle biopsy, and after an ORP, ortho radiopathological meet, after that, if we fail to receive diagnosis, then we go for an open biopsy. So the principles of doing an open biopsy are tourniquet may be used, but there shouldn't be any exsanguination. You should avoid raising flaps. Directly go and reach the tumor. Go through the muscle instead of intermuscular planes, because if you go through intermuscular planes, those are areas of low resistance. So tumor can spread, and you'll have to resect more also while doing the definitive surgery. The neurovascular bundle should not be dissected or manipulated. And you can take tissue only from the soft tissue component of the tumor. You need not take it from the bone. Put an oval or a circular window. Send frozen section if needed to confirm adequacy of your specimen, and plug with cement to prevent hematoma. And once the biopsy is done, tourniquet may be released. Meticulous hemostasis is needed because the hematomas may dissect soft tissue and subcutaneous place and contaminate a larger area. Avoid placing a drain, but if needed, can be placed along the line of incision and closed in layers. And whenever in doubt, or whenever you're doing a biopsy or seeing a pus, always send it for culture. And whenever you're seeing a patient with bone tumor in the OPD or whenever you're examining him, the first thing after seeing the X-rays to tell them to be non-weight bearing or give them a splint and avoid fractures. Or even after biopsy, you tell them to. And it is fixed in a 10% formalin solution. This is a core needle, Jamshedji needle, and it is. And do not split the biopsy specimen. Like I told, the bone tumors are heterogeneous. So you send the entire specimen to a pathologist, and if you need a second opinion, you can take the entire blocks and slides and give it to another pathologist for a second opinion, but do not split the biopsy specimen. And talk to the pathologist, give them the clinical radiological picture. Any pathological fracture, if it is there prior to a biopsy, inform them because there might be osteoid which might interfere with their interpretation of diagnosis. Like I told, ortho, radio, and patho sit together and make a diagnosis. And what you should look for in the biopsy report, it should have a definitive diagnosis, at least a sarcoma. Sometimes the pathologist will give poorly differentiated malignant tumor. It could be anything. It could be a carcinoma, hematolymphoid malignancy. It could be a sarcoma also. So always get a IHC and get a diagnosis before doing any definitive procedure. So the goal of the biopsy is to obtain diagnostic tissue by minimizing morbidity and limiting potential tumor spread and to avoid interference with future treatment. And once a diagnosis is confirmed as to be a malignant bone tumor, the staging would be to do a HRCT chest plain and a bone scan, or if it is Ewing sarcoma, a PET scan is advised because a PET scan can replace the bone marrow biopsy in Ewing sarcoma. And this is the staging, AJCC staging, which we use for staging. For bone tumors, they divided into less than 8, more than 8 centimeters, and T3 is skip lesions. And any metastasis in a bone lesion, either node or lung or non-pulmonary mets, is considered as metastasis. And you can see these X-rays, all of them look almost similar, you know, lytic, expansile. So to get a diagnosis on MRI or X-ray is very difficult. Go with the biopsy. All of these lesions may look same, and most of them are treated with different modalities. So less than 40 years, always do an MRI and a biopsy. More than 40 years, always keep in mind, think of a metastasis or a malignancy like a multiple myeloma or something. You can, more than 40 years, if it doesn't look like a primary bone tumor, you know, like not a typical GCT, you can always ask for a PET CT. There's nothing wrong. And then you can ask for X-ray and full length MRI. Do not do a definitive procedure based on an MRI report or a FNAC report. Avoid fixing a pathological fracture without a diagnosis. Core needle biopsy should be the preferred modality of biopsy. And that's. Any questions?
Any queries? I kindly call upon our HOD, Professor Tulkapian sir, to felicitate Chandra Kumar sir. Thank you.
Case presentation starting now. So already got two more case presentation by Dr. Balakrishnan, finally a postgraduate from the Kilpak Medical College. So call upon, I welcome Professor Aswati sir to chair the session. Then Dr. Sambhkumar sir, please. Then Dr. Professor Kovina sir to chair the session, and Dr. Professor Sokalingam sir.
Okay.
இன்னும் கொஞ்சம் உள்ள பண்ணலாம்.
Good morning, sir. I am Balakrishna from Kilpam Degree College. A patient named Mr. Tanvi, 17 years, male patient, coming from MMDA colony, who is a right hand dominant person, who is doing his college first year, came with chief complaints of pain over the right distal forearm for the past 2 weeks and swelling over the right forearm for the past 7 years.
How much you said was the age?
17 years. And the swelling over the right forearm for the past 7 years. Patient was apparently normal 7 years back, after which I noticed a swelling over the right forearm, which is insidious in onset and progressive in nature. It is initially in the distal part of the radius and progresses proximally.
How do you say the radius on history?
It was initially in the distal part of the forearms. Progresses proximally. No aggravating and relieving factors associated with pain. She of pain for the past 2 weeks is acute in onset and not progressive in nature. No diurnal variation. The character of the pain is dull aching type of pain and aggravated on aggravated on activities and relieved on rest and medications like analgesics. No diurnal variation. History of difficulty in lifting heavy weights. No history of difficulty in buttoning and unbuttoning the shirt. No history of fever, loss of weight and loss of appetite. No history of any breathlessness. No history of difficulty in micturition. Past history, patient had during his 6 months of age, he had surgery over his right side of the neck while he was at 6 months of age. No issue of any previous irradiation. No issue of diabetes, mellitus, hypertension, asthma, and epilepsy or seizure. No issue of any other medications. And past family history, no relevant family history. Patient is is a second born child born to a non-consanguineous marriage and by previous by LSS due to the previous LSS done for her sibling. Is antenatal, natal, and postnatal paper uneventful. General examination. Patient is conscious oriented and active. No pala, no ictus, no cyanosis, no clubbing, and no generalized lymphadenopathy. Stature: patient height is 167 centimeter and weight is 67 kg and is appropriate for his age. Local examination. Attitude of the limb. Arms by the side of the body and elbow in extension and wrist in neutral. Local examination, inspection.
So at the stage of your history,
So that we can, sorry, turn in that way so that we can focus on this side. If they hit that side. Like is that what you need that? That's it.
Yes. Attitude of the limb, arms by the side of the body, elbow in extension and wrist in neutral. And
How many years did you say that thing was?
7 years.
7.
7 years. On inspection, a single swelling of size 3 x 3 centimeter present over the volar aspect of the distal part of the right forearm. The skin of the swelling is not stretched and shiny. No scars, no sinuses, and no dilated veins were present. No apparent limb lengthening or shortening is present. No obvious muscle wasting is present in the right forearm compared to the left side.
No, you said the attitude.
Yes.
You said how is the shoulder placed?
Arms by the side of the body.
Elbow?
Elbow in extension, wrist in neutral.
What about the fingers? You think the
It's not-
fingers are in the normal position in which you normally keep the fingers?
Yes, it's normal.
It's normal?
Yes, sir.
Okay. Right. So you tell the fingers are kept in a position of
Yes.
flexion.
Flexion.
You know, that's what
It's
is
a not, it's a new palpation.
It's not over. What's your local examination findings? Because you told about the entire limb now.
Yes.
Now come to the local examination here.
A single swelling of size 3 x 3 centimeter present over the
You are able to say the size of the swelling? Is it well demarcated swelling?
yes, it's not.
Is it normal? It's normal. 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 Are you able to say the confines or the boundaries of the swelling on inspection?
Not able to say well defined.
Then how did you say the sizes?
Okay.
Very difficult to say that, no?
Yes, yes.
Because it's a
Diffuse
diffuse swelling. Where exactly is the swelling?
Distal and middle third, the junction of the right forearm and volar aspect.
In the forearm,
In the volar aspect,
volar aspect,
the distal third.
distal third, middle third. Okay,
Junction.
right. It's a diffuse swelling,
Yes.
isn't it?
Yes.
Yeah. Okay, then approximately you can say right, but that is not the likely to be the right
Yes,
dimensions, isn't it? Okay.
And no obvious muscle wasting is present. No apparent limb lengthening or shortening is present.
Okay.
On palpation,
No,
No, inspection it's
no scars, no dilated veins, no glistening or shining over the skin.
no stretching of
Stretching of the skin. Yes.
right?
Yes.
You
Any-
have to tell the extension of the swelling also. Yes, noticing the swelling
Yes.
only in the.
Volar aspect.
Is it extending radially or ulnarwards? Whether it is going to the dorsal aspect, we don't know that.
See, when you say about the swelling, you're not able to say the margins of the swelling, right?
Yes.
You are not able to see the superior margin, you're not able to see the inferior margin,
Medial.
but you know it is extending entire
the
entire
volar aspects. The volar aspect.
width of the forearm and the distal third,
Yes.
right? But you are not able to see the margins.
Yes.
Yeah, nearly this.
Okay.
Clear? Okay.
Palpation.
Is there no redness or
No,
discoloration?
no, that is.
Is there any swellings are seen on the posterior aspect?
No, sir, no, sir.
So whenever you see the forearm, you should see not just from the front, no?
Okay, sir.
You should see from the sides, from behind, from the medial side also.
No
Isn't
other
it?
swelling elsewhere in the.
Not only swelling, this swelling where it is extending.
Okay.
Clear? So when you, especially when you're not able to demarcate the margins of the swelling, it's very important for you to see the other areas as well. Clear? Okay. So it is predominantly only in the volar
Volar
aspect.
aspect.
Okay.
Palpation, no warmth, tenderness is present over the swelling and
Is this a biopsy scar?
Ah,
no, sir.
is there a scar? The scar is, you don't think anything is done?
No,
Is it
nothing, nothing.
something incidentally which was there?
Yes.
Okay.
No warmth, tenderness is present over the swelling and
No warmth.
no warmth,
Okay.
tenderness present over the swelling.
Yeah.
On skin over the swelling is pinchable and on examination, 4x3 centimeter swelling present over the right distal third part of the forearm and an examination from distal to the proximal, I cannot able to insert the finger, but from proximal to distally, I am able to insert finger underneath the swelling.
Right. You said the plane of the swelling, you said the skin is pinchable.
Skin is pinchable.
Where
and
else is the swelling?
the
What is
bone-
the consistency and the thing of the swelling?
The
The dimension you said.
yes, sir.
Yeah.
Consistency is
Consistency?
bony consistency and it is not able to move in any direction.
It's a bony consistency.
It's
Okay.
not able to move in any planes.
It's not it's mobile, it's immobile.
Not immobile in any all the planes.
Which is attached to your bone.
Yes, sir.
Which bone?
I am able to feel the contour of the ulna is normal, so most probably from the radius.
No, you can't say that way, na. If at all, it might be in the interosseous area, isn't it? It's in the medium middle of the thing. It could be either come from the radial side or the ulnar side.
Yes.
So how did you identify clinically that it is coming from the, you said radius?
Yes.
Yeah, how did you say that?
From the radial styloid to the proximally, I am palpating the borders of the radius.
That's true, but how did you know that this swelling is arising from the radius?
Not able to confirm.
No, you're not able to make it out also. You said something about the ulna.
The ulnar contour is smooth, sir, from olecranon to the ulnar styloid.
It's smooth. See, ulna is more easily palpable on the,
Subcutaneous bone, so easily.
yeah, it's more visible. Can you palpate the interosseous surface of the ulna? Are you able to palpate?
No, sir.
No.
No.
You don't think the swelling is arising from the ulna,
Yes.
right? Yeah, I can feel a gap between the ulna and the swelling here, right? So, yes, most likely it is coming from the, oh, sorry. You said tendon is present or?
10%.
Right. So it is most likely to come from the
Radius.
radius, okay? It's immobile, you said,
It's immobile in all the planes.
okay.
Um, movement. Movement.
Now, you see, you said about the skin,
Yes.
right? The skin is pinchable, the
Pinchable.
skin is not involved in the swelling.
Okay.
You said it's arising from the bone.
Yes.
In between the skin and the bone, there are a lot of other soft tissue structures. Na?
Yes.
Are they involving those structures?
It is deep to the muscle planes. Deep to the muscle plane on a
It's deep. It's not involving the muscles.
muscle, not in
Is it not involving the
not
muscle?
involving.
How did you say that?
By making the muscle taut, the swelling.
So you are saying it's deeper.
Yes, sir. Deep.
But any swelling can involve the muscles also, na? Isn't it? Yeah.
If it involves, it will be prominent.
So how do you know the muscles are not involved in this patient? Yeah.
So if it involves the muscle on tauting the muscle, it will be prominent. Swelling will become prominent.
Okay, one. If it's involving the muscle, it will be prominent. Did you make the muscles taut and
Yes, yes.
thin? It's not visible better?
Yes, sir.
Can you just show how you did that? Let the camera come. You come this side and do. Yeah. Yeah.
You try to push it.
Is the swelling becoming prominent or less prominent? No, you're seeing, na? Relax panungo, sir. Okay.
Prominent.
Press panungo. Is it becoming prominent or improminent?
Prominent.
Prominent. But you said it's not becoming prominent. Okay. How else can you say that the muscles are involved in this condition or not?
Direction of the plane of the muscle movement, there will be pain.
No, if it is arising from the muscle, it's a different issue. If it's arising from the muscle, the swelling will be mobile only from side to side. It will not be mobile in the longitudinal axis, right? Any longitudinal structure, not muscle alone, can be nerve, it can be tendon, whatever it is. What I want you to tell me is these flexor muscles involving by the tumor or not? How else can you make out? One, you said prominence of the muscle. What else? Now the muscle is, the swelling is prominent, na?
Yes.
So you think it's involved or not involved? Could be? Could be, okay. So then what you can also do is, look at the movements of the passive movements of the
So
joint, right? So if I am able to dorsiflex the wrist completely, then I know that these muscles are not probably involved. If they are anchored, if there's a involvement of the muscle, then the muscle will be anchored at that stage. Then I find that passive movement of the wrist joint will not be allowed by that muscle because it will be anchored,
yes.
right?
Yes.
So that is another way of trying to find out if the muscle is involved in that area. Clear? Okay. So you think it's involved or not involved?
Since the movement is not involved.
You don't think it's involved?
Yes.
Okay, go ahead.
It's not able to move in a all.
Okay.
Elbow flexion is a 0 to 130 degree and is a full range of degree without any restriction of due to pain and person. And supination pronation 0 to 70 degrees present on the right side, 0 to 80 degree present over the left side.
What?
Supination.
Okay.
Pronation is 0 to 70 degree on the right side and 0 to 80 degree on the left side. 10 degree restriction in both supination and pronation on the right side.
Can you just demonstrate?
So you're getting both movements, but it is only
Restricted. In supination, 10 mil range of like 10 degrees
Only the
restriction
10 mil range.
is in both supination and pronation.
Is it restricted with pain or is
Yes,
it
sir.
mechanically restricted?
Restricted with pain and also mechanicals.
Why is it important for us to know?
If bony block will affect the
Yeah, if it is a mass which is producing the restriction of the movement, then it will produce a mechanical block, isn't it?
Yes.
Okay. So you want to show supination, pronation. If it is sir, like okay. In the book, full. See, ideally, you should look at the forearm. You should look at just the put a pen and do it.
Okay.
Because there will be movements in the wrist which will sometimes
false.
correct the so-called restriction.
Okay.
Clear? So there is a restriction of terminal supination, pronation. And
Supination.
even supination is not complete.
It's restricted.
It's restricted. It's painful in the term.
Painful.
Okay.
Next, measurements. No, arm and forearm are equal in size compared to the opposite side.
Is there, see, you said that swelling is coming up. You didn't say whether there's any thickening of the bone. Did you say anything about the bone status at all? You said it's arising from the radius. What about the rest of the radius?
Normal contour is.
It's important for you to say that. Now, why is it important for you to say whether the rest of the radius is
Skip lesion, maybe.
skip lesions? Why do you have to say the rest of the radius is normal or the radius thickened or not? Why is it important for you to say? If it's a medullary canal lesion, intramedullary canal lesion, then the entire bone is likely to be expanded or thickened, right? If it's coming from the cortical surface or one of the surface areas, then only that portion is likely to be involved, right? Rest of the bone may be normal. So that is why you can at least have an idea whether it's coming from the inside the medullary canal, where the entire bone is likely to be expanded, or is it coming from one surface? Yeah. How is this bone?
Smooth and
Rest of the radius is okay.
Yes, sir.
There's no thickening of the rest of the radius.
no, sir. No,
Ulna?
regular. Yes, ulna is smooth and regular.
Okay.
No distal neuromuscular deficit, and pulse was equally felt on both sides. Radial pulse equally felt on both sides.
What neurological deficit I need to know?
So, no,
What neurological deficit did you see in this patient? Examine for.
radian now, the median now, the ulnar.
Median now, what test did you do?
Okay, science. Like
The median now, if I ask you, what are the tests you will do for the median now? In this patient?
because first check the autonomous zone of the median.
You have motor and sensory.
Sensory.
Motor, what will you do? Sensory, what will you do?
Pen test will be done.
Pen test. Okay.
Then if
Ostner's clasping sign,
Yes,
pointing index you'll do?
yes, sir.
Yes.
Then there will be no ape thumb deformities. Ape thumb deform.
One thing you have to realize that if the lesion here is involving the median nerve, do you think it will produce a pointing index sign? Yeah, anyone thinks in the audience that the involvement of a median nerve in this area is likely to produce a pointing index sign? Yes, anyone in the audience? Yes or no?
TP is release.
Yeah, these muscles are innervated more proximal.
The TP is already
So
separated.
probably the only real motor deficit you can look at it from here is what are they?
Thenar muscles.
You will look at the thenar is a good muscle for you to look for, right?
Yes.
So the muscles of the thenar eminence, yes.
First two lumbrical.
Others will not for the median nerve because you said it's on the radial side. Ulnar side? You look for all the muscles?
Yes.
What are the innervations you look for?
Sir, all the intraocular muscles, cord test.
Okay. So they are all normal.
Yes, sir.
Sensations?
Senses intact.
Intact. Radial nerve?
You said radial nerve also, no?
Yes.
Do you think
No,
there will be a problem with the radial nerve because it's mostly swelling in there?
Polar aspect.
Yes.
Even then, do you think a radial nerve will produce what lesion if it is there? If it's on the dorsal side, if this lesion was on the dorsal side, what problem will it produce, radial nerve?
Maybe superficial branch of radial nerve, ceralgia prosthetic.
Motor deficit?
Nothing.
Nothing. Correct. So you should know that,
Yes.
right? So here, even if it was on the dorsal side, you would at the best get some sensory problem.
Yes.
You may not get any
Motor.
deficit. Yeah, at this level. Okay, so but there are no neurological deficits.
No
as
neurological
well.
deficits.
Sensation is also
Senses intact.
vascularity is also
Vascularity.
right. Now this swelling, when you said, you didn't tell us about any of the other structures. You said about the hardness, consistency,
Skin.
but the other things also you should say whether it is
Compressible.
because it's the root of artery, right? So you should also say about those things.
Not
whether
pulsate,
they-
not compression, not
yeah,
reduced.
all that also should have been a part of your
Palpatory examination.
palpation finding. Okay, right.
differential diagnosis.
You didn't look for lymph nodes,
Yes.
huh?
No epitrochlear, no axillary, and no supraocular lymph node enlargement.
Epitrochlear lymph nodes you look. Where did you look for epitrochlear lymph
One
nodes?
center above the medial epicondyles.
Palpate.
Palpate the supranuclear ridge and the
How
medial
will you keep the elbow?
flexion.
Okay, what about the axial lymph nodes?
So I have to abduct the forearm and check for
You should abduct the
Arm.
axilla, put your fingers right into the axilla, sorry, abduct the shoulder, put your fingers right into axilla and then bring it down. Right, then only you can palpate on the anterior, lateral, posterior group, central group of lymph nodes and all that. Okay, right. So no lymph node, no.
no lymph node.
Any joints, proximal, distal,
Yes, yes,
Said
other,
elbow
all
joints.
other joints from elbow.
Normal.
you have to look for the distal radial agent also. Sometimes there may be
Yes.
He said
Yeah.
supination,
storage. Okay.
terminally restricted. Okay.
Differential diagnosis. Case of
Short findings of
okay. 17-year-old male patient, painful swelling,
For 7 years duration.
for 7 years duration, slowly progressive, swelling growing away from the joint.
Away from the joint, how did you make it? Which joint did you say it's going away from?
From the distal radial node.
So it's going,
Yes, sir. From the history, patient told that initially it was in the distal side and it progresses proximally.
he said that.
Yes.
Very observant patient, right? Yeah, okay.
Consistency is smooth, bony consistency, smooth, surface is smooth.
Rest of the radius is not involved according to you. Okay.
So if you see a swelling in a growing skeleton like this, what else you'll do? Anywhere else you look for?
Sir, you have to check for a distal femur proximal tibia.
Mm.
Most common site is then proximal femur.
Mm.
Before check for other multiple swellings,
Always-
red swells in the body.
If you have heart swelling like this,
Yes.
you have to rule out the possibility of other
Others,
levels and other common sites of your that is not there.
it's not.
Okay. Sure. Sir.
So you should tell us, is this a benign lesion or a
So benign lesions.
benign lesion?
Benign lesion.
What are your points in favor of a benign lesion?
Sir, the surface is smooth, sir. Not a surface is smooth and hard in consistencies. Not
So
a-
hard consistency, you cannot have malignancies.
we may have, sir, but in malignancy there will be variable consistencies. Mostly,
Okay,
most probably.
okay, okay.
Skin may be, skin is not pinchable, yes, so not involving the skin. No loss of weight, no constitutional
Now
symptoms.
you should come in an order that way. Yeah, you should come in an order.
From history,
No constitutional symptoms, history, long duration, all that and come to the local area, right?
yes.
Okay, local evidence of malignancy is there or not there? What are the features of malignancy normally you expect?
Involving dilated veins,
Dilated veins,
pulsatile,
okay. Pulsatile is
skin puckering.
maybe a tumors
Yes.
also, vascular
Yes.
tumors, yeah. What else?
skin puckering,
Okay. Soft tissues involvement
Soft tissue
around the
involvement.
structures, right?
yes. Sudden increase in
Yeah, sudden rapid rise, okay. So there is, you think it's a benign lesion?
benign lesion.
Why is it tender? Is tenderness a feature of a benign lesion or a malignant lesion?
That is the feature of malignant lesions.
Malignant lesion.
Mostly.
How long is the lesion tender?
For him, 2 weeks, sir.
Only 2
2
weeks.
weeks.
Then you tell me a lesion swelling which was there for 7 years, which was, he did come for treatment then.
Yes.
So he's come now is because it is
Pain.
painful for the past 2 years. Why should it become painful now?
So he told that it's a trivial trauma.
What
While
was the trauma? Was there, you told him the history?
listens.
Huh? No,
I didn't.
he said in the history?
No, sir,
No. What was a trivial trauma?
Like he put his hand over his friend's shoulder. After
You
that,
think
no,
Because of that, it will produce a gross problem here?
no, sir.
Then
Sir.
trivial trauma. I think all of us, when you go to the coffee break, you put your hands across your friend's shoulder and go. Does it produce a problem? You can't call it trivial trauma either. So what happened now in the past 7 days for him to have pain there?
Be soft tissue involvement.
But you said there are no soft tissues involved.
Clinically cannot able to
What are the causes? You said it's benign lesions. You said it is only coming on the anterior surface of the radius. Till that we have accepted. What are the causes of pain in such a lesion for the past 7 days?
Bursitis can be.
Bursitis.
Is it possible in 7 days?
2 weeks.
What are the other problems which you can have?
Pathological fracture.
Yeah, because what if I say it's a malignancy?
So
A
sudden
swelling which was there is now having a malignant change. Will you accept it or not accept?
rapid increase in pain, we can suspect malignancy.
You will suspect malignancy. Now this is an isolated swelling coming from the radius. It was closer to the wrist joint, it's come into the middle. What is the likely benign swelling which occurs like that?
That's it. Metaphysics to diagnosis, so osteochondroma maybe
Why, if it's a cyst,
unusual bone cyst can be present.
I'm saying this is an aneurysmal bone cyst. You said all features of benignity. I'm saying it's an aneurysmal bone cyst or a simple bone cyst there.
So insulate the fingers underneath the swelling.
That is why it is important for you to say the dimension of the radius at that level, whether it's thickened or not. Aneurysmal swellings will be expansive,
Expansive,
right?
eccentric.
So the entire bone is likely to be thickened.
Thickened.
Whereas if it is something like you are thinking about, then it may not. Okay, so you think it's a
Give a differential diagnosis. Main tumor of the distal part of the forearm, most probably arising from the radius. First differential diagnosis, pedunculate osteochondroma. Second differential diagnosis, aneurysmal bone cyst.
No, you said in your clinical findings, there is no thickening of the entire bone.
Yes.
Entire bone was normal. Then why suddenly for because of us, you are changing the name? You are definite with
Yes.
the osteochondroma. Why you want to change now?
you think it's osteochondroma is your like. You can always, you're
Yeah.
in the exam, but you're safe to give a differential diagnosis.
Yes, yes.
I'll always say that don't get stuck to one diagnosis and be proved wrong. It's always better to give a differential diagnosis, giving the examiner the impression that there could be other possibilities also, right? It may not be the two possibilities that you thought, it might be a third possibility, but at least you thought like that. Okay. So you're thinking that it could be, but there's nothing to, is there anything to suggest an aneurysmal bone cyst?
So age of the patient,
Age of the patient.
vague pain will be present in aneurysmal bone cyst.
Aneurysmal, 7 years is there. Right. So you think your diagnosis is?
Pedunculated osteochondroma.
What are the chances of a pedunculated osteochondroma becoming malignant?
If it is solitary, less than 1%. It is multiple, 5% to 50%.
What are the other causes of pain in a osteochondroma?
Sir, perilesional bursitis, pathological fracture, a necrosis of the osseous component, the malignancy transformation.
Can also होता है adjacent neurovascular structures.
As a
Yeah, mechanically
impeachment.
producing compression on tendons, muscles, nerves and
Impeachment
all
of-
that. Right. So you think it's an osteochondroma? Yeah? The tenderness is, the tenderness and pain is due to the, according to you?
Bursitis. Bursitis.
Yes.
So what do you want to do?
So I have to do an X-ray.
Yeah.
Being a very simple case. What is the name? Bursa called Bursa. Is there a specific Bursa there? Named Bursa? No, is there a name?
It's not the site of a regular person. Then what is that bursa called? That is the question he's asking. You said bursitis. So he wants to know when it's not a named area. For example, prepatellar bursa is a named area very well. Or a suprapatellar bursa or infrapatellar. There are areas where bursas are present. He says this area there is no bursa. Then what is that bursa called? Hey, what is that called? Yeah. When a bursa is not there in its regular place.
Yeah.
Huh? Adventitious.
Yeah.
Right? Okay.
Bursitis exostosis.
Advantage is bursa. Okay. So what do you want to do for this?
Do a radiological imaging, X-ray APN lateral view for the right forearm with the wrist joint APN lateral view on the both side and the pelvis and the knee joint APN lateral.
Why you want to do all that?
So to rule out maybe any other swelling present as well.
Multiple exostosis
Multiple.
you are thinking of.
Yes.
Clinically, it's not.
Clinically non.
You're thinking of hereditary multiple exosomes.
No.
Ah,
Just in case we mix it. So we are doing X-ray, so we can.
yeah, but that might be a little, okay, right. You
Don't
want
take
to-
radiological investigation very lightly, it is exposure. So with a single X-ray, can you just guess whether it is multiple or you solitary?
See, you should remember, isolated single osteochondroma is different from a multiple exostosis, right?
Yes.
They're different.
Yes.
So the question is, if this gives that appearance, then there is a reason for you to investigate the rest of the area. Okay, okay.
So with a single X-ray, you can be suspecting whether it is diaphyseal ecclesis or multiple exhaustosis or a solitary
Knee
exhaustosis.
joint.
No. Even
This
in the
X-ray,
same
doctor, forearm.
Yes.
When
Can
you look at the X-ray,
suspect.
you can you or can you not suspect? You want an X-ray, no? There's the X-ray.
Uh,
That would. Yeah. X-ray of a skeletal immature person.
And what did you say? You could feel it when you came from distal to proximal. You said something.
Yes.
What did you say?
Insulate the.
You could.
Yes.
You do think this is typically like that? Well, I couldn't make out any of those things. In case insinuation means from where should it have come?
From proximal to distal.
Ah, proximal. But you said from distal to proximal.
Proximal to distal.
Huh?
Yes.
Okay, now describe.
So the X-ray of a skeletal immature person showing a right forearm with the wrist joint, elbow with the forearm with the wrist joint, AP and lateral views.
You should always say skeletally immature.
Immature.
You should always say that also. So you were told in the previous class that you had also. It's always important to say, right?
Showing a pedunculated tumor with a calcified ends. There is a continuity between the cortex and the tumor is continuous with the cortex and middle of the paranhymns radius. And it is in the between the radius and in the interosseous regions. No periosteal, no periosteal reactions.
Okay, so what is the bone doing? Rest of the bone is normal, radius.
Sir,
So if you are having a hereditary multiple exostosis also, you will have failure of remodeling, etc. in the metaphysis. Metaphysis will be dilated,
Widening
expansive, etc. Suggesting that this is not a regular exostosis. So you should look for, you may have other areas of, okay. So this is, according to you, an isolated, most likely.
Yes, solid.
Okay.
How to say it is only isolated? Why don't it be a multiple exosomes? So where will you get in a multiple exosomes? Lesions will be there. Which part of the radius?
So radial Masara classification type 4, there will be distal part of the radius. Type 1 in the distal ulna and
Yeah. If it is a multiple means, it will be more towards the growing part.
Yes.
That distal end. That will be typical. So it is very clear that the solitary.
You said it's in the metaphysis. If this was in the epiphysis, what would have been a diagnosis?
osteoclastoma.
Osteoclastum.
Not this.
Pedunculated tumor like this.
Pedunculated.
Yeah.
Yes.
What is it called?
Traverse.
Huh?
Yes.
Traverse.
Yes.
Traverse disease. Okay. Right. Okay. So now, hey, MRI potacha. So now what do you want to do?
So we'll do MRIs.
Why?
So to see the cartilaginous cap. If it is more than 20 mm, it will be more prone for malignancy. And any soft tissue involvement or nerve involvement.
You want to know the cause of the pain.
Yes.
Yeah. You want to know the cause of the pain. Okay. Say report on this. இது ஒரு பிக்சர் தானா? Okay. Right. So is there cartilage gap? Show the previous.
Yeah.
Calcification change.
Will stipple this.
In this case, what about the cartilage?
It's uniform. Uniform thickening.
Is it more than 2 centimeters like you said? No. Yes, sir.
No, sir. I can't. Sir.
You said bursitis. Then where's the bursa? Bursa should be visible, na?
Yes.
Yeah.
Second slide.
You want to see some sections more? Where are you? Not really. Is there a bursa?
I'm unable to.
So what are the other likely causes?
Fracture.
Fracture. Fracture you are able to see?
Yes.
Ah.
Osseous. Necrosis of the osseous component, bony.
So if bony, will the MRI pick it up or not pick it up?
Impingement.
Yeah, impingement of the soft tissues. This may be the cause of. But why should impingement occur suddenly after so many years? But that's a possibility. Okay. What do you want to
Yes, sir. Now only for past 2 years, he was pain free, sir.
What is the usual presentation of an osteotomy? What's the first presentation of an osteotomy? Yeah. The first presentation of an osteotomy is pain. The patient comes to you with pain. That's usually the first, not a swelling. Not usually a swelling. Why are you not thinking of terms of infection? Here's a metaphyseal swelling, painful. Why you are not thinking in terms of infection?
So the patient has no any history of fever and no history of.
Is it tender, thickened, irregular, bone, tibia?
There's a patient has tenderness on the medial lateral borders and palpating.
Is it tender or
Yes,
not?
tender.
Metaphysis.
There's a tender.
Is that a tibia thickened,
Borders are thickened and palpating.
irregular?
It's not irregular, sir. It is regular. In palpating.
So you never thought about infection also?
So I had a second differential.
No, but you did. You gave a diagnosis for an osteoblastoma, which to me is radiological or diagnosis with a swelling first and with no pain and pain coming after 1.5 years after that.
You want to offer any differential diagnosis or you want to stick on to osteotomy?
Give me a differential like.
That's what would have been sensible to start with, right? To give a differential diagnosis. Is there any malignant evidence of malignancy in this patient?
No, sir. Along the skin alone is stretched.
Stretched and shiny, rapidly growing. I can see the skin is stretched, right? Yeah. And there is pain, onset of pain now, which was not there earlier.
Yes, sir.
How is there any prominent veins?
No, sir. No, dilated veins.
Is there any warmth?
Warmth is present, sir.
Warmth is present. In spite of all that, you never thought about infection. And never thought about malignancy.
There was no any sinus tract.
Huh?
In inspection, there was no any sinus tract was.
There was a surgery done, na? Then why it has occurred
Contradict
again?
on benign from malignant and from infection to malignant, sir.
Huh?
Can you do differential diagnosis like that or?
No. I would think a differential diagnosis of a metaphyseal swelling, pain and all that, infection is always a possibility of a DD. That I would always accept it. But you are very strict on osteoblastoma. That is very difficult for me to digest.
Not offer any differential diagnosis.
I would have thought
Osteomy.
the most probable, if I were in your place, I would have thought of two possibilities. One is an infection, one is a tumor. Both can present similarly, clinically. I haven't seen the X-ray, right? But clinical features might be very similar to each other. I would never have thought about osteoblastoma unless there was something very specific. You said pain is relieved on analgesics. Most of the pains get relieved or reduced to some extent on analgesics. Yeah.
Patient is
So what do you want to offer? First is osteoblastoma, second one is
with osteomyelitis.
osteomyelitis. Third diagnosis.
Osteosarcoma will be third diagnosis.
First is
With this order of presentation of your DD, the first my diagnosis will be that you have seen the X-ray, right? Basically, I would think that is what has happened because your clinical findings should not have come in the order which you have said. I would have thought about infection or a malignancy in this age group. He's 17, 19 years.
19 years old.
18 years old, metaphyseal tumor, rapidly growing, prominent, painful, local warm, stretching of the skin, etc. And you never even considered a malignant possibility or an osteosarcoma. That is, to me, is very difficult to digest. Okay.
You want to offer any?
So there is definitely an engaged saphenous vein. If the camera can show, if you can come around this side, the long saphenous vein you can see is very prominent on this side.
She underwent surgery, biopsy on 2022.
Yes.
See, we started off with a diagnosis, right? So I can understand you not giving us this, but you have asked the history also. I don't know the history, but from looking at the clinical examination of the patient, one thing is for sure that you should have kept these differential diagnoses definitely in mind.
Yes. Say yes. Yes, sir.
Not yes, it is true. If this patient had come to your clinic also, you would have said yes. You should have said that. Okay. Right, so what is your final diagnosis if you say?
Final. Good for you. A case of malignant tumor arising from.
So you can stick to a differential diagnosis, even with the X-ray previous
Hey.
lecture.
I told you earlier also, it's always sensible when you do not know you're not, everything is not fitting in correctly to give a differential diagnosis. That's always nice. And DD, you can put infection also because infection always is a differential diagnosis for a tumor. Yeah, so you are safe to do that. Yeah. So you say the possibilities are, if I am in your place, I will say the possibilities of what are your differential diagnosis, I will say tumor or tumorous condition and infection is the two things I am keeping in mind for whatever reasons. Metaphyseal, TPL, local warmth, prominent veins, growth, pain, all that are similar to an infection. Similar features will come also, right? Okay. So
What do you want to?
what do you want to do for this patient?
Take X-ray to
X-ray,
X-ray of right leg, sir. Maybe a lateral view. to take.
right leg with knee and
Uh,
entire limb you would like to take an X-ray, yeah? Including the knee. Yeah.
Digital X-ray of skeletal mature individual showing the right leg with the knee joint. A single intramedullary expansion lesion present over the metaphyseal diaphyseal.
Is it a lytic lesion or a sclerotic lesion?
It's a sclerotic lesion.
It's a sclerotic lesion.
Yes, sir.
The medullary canal is visible? Is it? Yeah,
Yes, the medullary canal can be visible.
it's fully visible?
No, sir. At the level of the lesion, it's not visible, sir.
Metaphyseal lesion, it's not visible.
Yes.
Okay. Is it expansile?
Expansion lesions, sir. Cortical thickening is.
When do you call a lesion is expansile? Technically, when do you call it a lesion is expansile? When it is bigger than the adjacent physis. Right? Epiphysis, sorry. Adjacent epiphysis. If it's bigger than that, then you call it a expansile lesion. So it is thickened all round, isn't it? You can see in the AP view and the lateral view, everywhere the bone is thickened. Cortex is definitely thickened. Medullary canal not very well visualized. There is some obstruction which is seen in the medullary canal, probably because it's all round there, right? Okay.
What else will be? Narrow zone of transition. Narrow zone of transition is.
You are able to see a narrow zone, where it ends and where it begins, you are able to see.
Yes, sir.
Is this evidence of a benignity or malignancy? This X-ray picture.
Benign.
Why? What are your points in favor?
Sir, there is no any cortical breaches there. There is no any periaxial reactions can be seen, sir.
What does this thickening suggest?
Sir,
What is the bone doing to the lesion, whatever lesion it is? Has it time to act or not act?
yes,
The bone, the parent bone?
sir.
The evidence of sclerosis tells you that the parent bone has reacted to it in the form of, it's got time, right? It's been there for a long time. It's not rapidly involving that. So it is thickened, sclerotic all round. Clear? Okay.
I think whenever you describe the lesion on the X-ray, there are 4 questions you ask, doctor. This is King's 4 questions. Where is the lesion? What is the lesion doing to the bone? What is the bone doing to the lesion? Are there any intrinsic characteristics suggestive of a diagnosis? Sometimes you look at the X-ray, you know the diagnosis, like the exostosis. So here, the lesion is in the metaphysio-diaphyseal junction. What is a lesion doing to the bone? Generally, lesion will create a lytic area. Can you see any lytic area in this? I can't see any lytic area. So maybe the lesion is somewhere there. Unless it's a secondary like prostate, there will be a deposit or sclerotic deposit. Generally, tumors create a lytic area. I can't see a lytic area. What is a bone doing to the lesion? If there is one, it's creating a lot of new bone formation. So the cortex is thick all around. That is a newborn formation, secondary to some pathology going on there. Is there any periosteal reaction? No periosteal reaction. The medullary canal is narrow because of the hypertrophic bone formation. So if you just look at this pathology, it doesn't look like malignant, doesn't look like a benign lesion. The bone is trying to arrest something which is going on there. So it's most likely to be a
What are the,
Most
what are
likely
the possibilities after seeing the X-ray now?
so it is not
Huh?
it's not a malignant lesion, doctor.
It's not destroying the bone, right? Yeah. What do you think is happening now? After looking at the, even now you can give a differential diagnosis. Yeah. It's not malignancy, you think. You said osteoblastoma is there? You should ideally see a nidus if you want to see an osteoblastoma. I am saying this is osteomyelitis of Gary. What is your problem? You are aware of that osteomyelitis of Gary? It will look with a radiological picture which is sclerotic, no evidence of infection as such. It could be an osteomyelitis of Gary. What's your problem? Yeah. So even now you cannot really say ki it cannot be all that, isn't it? Yes. It may not be malignancy of the osteosarcoma or anything like that. What do you want to do now? Huh?
Ready to take CT for the
CT you would like to do. Why CT? Why not an MRI? Because the talk earlier said that you could have done an MRI. Why you wanted a CT?
to see the bony margins.
Yeah, the bony features are better seen in a CT. Osteoblastoma, what is the investigation of choice? CT or MRI?
CT.
CT, correct. Right? So CT would be, if you thought of osteoblastoma, CT would be the investigation of choice. Okay, you want to do a CT, is it? Yeah.
Again, whenever we do project the CT scan, always start with the axial cuts. Rest of the cuts are all reformatted. Yeah, so you always start with the axial cuts. So what do you see on the CT scan?
So nidus can be
Huh?
appreciated in CT.
So you see a nidus?
Show the axial cuts, pa. No, X-ray, CT. Yeah, this one, yeah. Where is the nidus, doctor?
So the below cut there.
Which one, sir?
So the inferior third cut can see the radiolucency center along with.
See, I think you're fixed on osteoblastoma. So you're finding it difficult to come out of that thought. Eh? Osteoblastoma, if you have seen one, that will be a very small nidus, usually seen on CT scan, with a lot of bone formation around that lesion. It won't be a uniform thickening of the cortex as you see here. So I think you have to get the osteoblastoma out of your context. This is looks like as Sir said, this looks like a sclerotic type of osteomyelitis described by Garrett. Okay. So your differential diagnosis is chronic osteomyelitis. But the problem with the Garrett sclerosing osteomyelitis is
not infective in that true sense of the word. Right? You get pus and all that.
You don't get an organism, so we do not know for sure. That's it.
Right? So yeah, but what I'm trying to say is please keep an open mind. Don't go with just because someone told you, your friend or your someone so-called well-wisher has told you that it is osteoblastoma. Don't come and present it there. Keep an open mind when you come here. Clear? So that you will think about rationally. So that the examiner will know that you are thinking about all this. Yeah, that's very important. More than diagnosis.
I think the key message whenever you describe lesions in the bone, always remember the Eneking's 4 questions. Again, I'll repeat it. One is, where is the lesion? Number 2 is, what is the lesion doing to the bone? Usually it creates lysis, except prostatic secondaries, some rare type of Gress secondaries. Primary bone tumors usually cause lytic area. Third thing you look for is, what is the bone doing to the lesion? Is containing it. So if it is containing it in a very well-defined manner, it is benign lesion. Sometimes you get a geographical or a moth-eaten appearance where the bone doesn't have time to create a border. Yes, so that will give you a clue whether it is malignant or benign. The last thing is some of the tumors, by looking at the X-ray, you know the diagnosis, like exostosis. So there you can, are chondral tumors, that's calcific deposits. So these are the 4 questions you ask. And you can repeat that when you describe an X-ray. Well done, doctor. I think you had a problem because you fixed the osteoblast in mind. So whenever the examiner is asking you, you are defending him, defending yourself, why you think of osteoblast, but you could not move out of it. Okay, thank you.
The most important take-home message for the students will be in this case is when the examiner was asking you, could it be osteomyelitis? First, to concur with the examiner because after all he knows little more, and then don't argue with them. There is no sinus. That should not be the response. So all the osteomyelitis need not have sinus. All the osteomyelitis need not have fever and episodes of all those things. Okay. So when you start doing that, what the examiner will think is you're not keeping that option in your mind at all. So don't give that option opinion to the examiner. So when they ask whether it could be osteomyelitis, what are the possibilities? So it is an art of examination, right? So definitely you will get some clue. So don't get carried away with the clue remaining. And in the CT also you are stuck to the osteoma because the way you pointed out, before we could realize that there was a lesion, that you have already located the lesion and where it was, and you are trying to jump and tell. And you are trying different. So the examination is not about correct diagnosis. It is not at all about telling the right diagnosis at that point. So it doesn't mean that Sar was mentioning it is osteosarcoma, it is like, so it is not that point at all. So it is only how your thought process is. Whether your thought process is in the right direction, swelling, so much it is there, the scar which is extended, so you are thinking that it is rapidly increasing, you are keeping that also in mind, all those things. Okay, right.
I just wanted to add on that. See, when you have a swelling for 2 years, it's very unusual to have a malignant swelling. And there's a history of some surgery on scar, of excessive remissions you should have asked. And in a metaphyseal swelling, usually osteomyelitis is a differential. If you don't have osteosarcoma, the other differential is an osteomyelitis. So, and the examination on the investigation of choice would have been an MRI to differentiate the soft tissue extent, the corticomedullary differentiation. CT will sometimes miss an osteomyelitis. So the investigation of choice here is an MRI, right? So your differential beginning should have been a subacute osteomyelitis in that child.
I think they have an MRI also. They have an MRI. And osteoma, again, that the APV and laterally you don't see that kind of the eccentric sort of in one cortex around the lesion will be the max.
Yeah, and it has to be of a particular dimension to call it an osteoid. Otherwise, it becomes an osteoblast. If it's more than a centimeter or so, then it becomes difficult for it. And many of the X-rays may not show that nidus because it may not be in the AP or the lateral view correctly. It may be somewhere in between. So you don't know which section is that. Yeah. So if you think of osteoma, then the investigation of choice is CT. Right. But by and large, since you didn't keep your mind open to others, that is why an MRI was not thought of at all. So like Dr. Shingarvadivel was trying to say, and we are all trying to say is, your thought process is more important. What you keep in mind, what you see the child or the boy patient, how your mind is thinking, that is more important to the examiner than your diagnosis. Yeah.
Sir, is there no nidus for the mind?
Yeah, maybe a nidus.
Yes, sir,
maybe a
that is-
nidus.
Yeah.
Maybe. See, normally nidus is well defined. Usually well defined. Right? And the newborn formation is all round. It's all round the bone.
Yeah, they've actually had a previous surgery for radio frequency ablation for osteoid. This patient has had a.
When you do a radio frequency ablation for an osteoid, you never get a tissue diagnosis most of it.
Yes,
right? It's a radiological diagnosis that you make. We don't know how it was at that time. But one thing is for sure, there is a newborn formation all around the circumferentially of the tibia.
There, but the drill hole you can see that into that nidus exactly, sir.
Yeah, maybe. That nidus, that is what I'm saying. It's not the cortical portion. You look at this area. There's a cortical lytic area.
Yes, sir.
So that is the medullary canal. This is in the cortical area. So I am not too sure about the diagnosis still. I'm not at all convinced that this is a osteoid. So I would like to rule out infections. It may not be malignancy, definitely. Infection is something which I will.
We'll have to keep the infection definitely in mind, sir, but
Because-
osteoblastoma definitely.
Osteoblastoma, I don't think we can entertain the diagnosis of osteoblastoma. Osteoblastoma is usually a small nidus, very difficult to find on the X-ray, surrounded by a lot of sclerosis. As I said, it will be eccentric. It will not have a circumferential thickening of the cortex. If there is circumferential thickening of the cortex, you see with the narrowing of middle.
Osteoblastoma as a clinical diagnosis, definitely we cannot accept. Unless there is definitely a relationship
even on
to his, aspirin or something. That if it is history is there, then we can probably consider that. I'm not sure. I came little late, so I was not sure about the history.
Usually an osteoblastoma relieved with analgesics. It will, I take a tablet today and for next 1 or 2 days, 3 days, there will not be any pain. That's how it behaves.
Usually.
Whereas if I have to take thrice a day analgesic, that means it's not, just because it's relieved doesn't make it osteoblastoma. If I take a tablet today, for the next 2-3 days, I will not be having any much pain at all. Usually that's the way they.
After seeing the X-ray, even I was considered, I considered Gary's osteomyelitis, sir. But seeing the CT, and definitely I feel there's a nidus there. I think after the CT, probably osteoblastoma will definitely should be considered.
I think osteoblastoma will be eccentric. It cannot have a circumferential thickening. If there is a circumferential thickening, very unlikely.
Sir, CT-guided biopsy was done for this patient, sir.
Yeah.
CT-guided biopsy was done for this patient, sir. It came out as fibroosseous lesion. And MRI that we have done, they have given there is a nidus supplied by a branch of the antitibial arteries. This patient. So
the MRI is very difficult to diagnose. It will show evidence of edema. Usually an MRI in an osteoblastoma will show evidence of edema. Very difficult to differentiate between osteomyelitis and the so-called osteotomy. Right. So X-ray MRI in a osteoblastoma is not a very helpful thing to do. CT is for osteoblastoma where the cortical defect is best seen. And a biopsy was done. Why is the patient still having pain? Because usually it's a biopsy when you do, it's an excision biopsy which happens. Even if it is CT guided. Even CT guided, for example, if I have a lytic lesion like Thiru was saying, and if I'm not too sure whether it's an osteoblastoma or I'm not sure it's osteomyelitis, then the thing that I would like to do is go in with a CT guided, do what is an excision and send it for biopsy. And the excision itself will relieve the pain of an osteoblastoma. It will also give us a tissue diagnosis. The only reason why a radiofrequency ablation or nowadays a microwave ablation is done is because it burns about 1 centimeter or so all round. So there is no nerve endings left behind. It becomes pain-free at that.
I think the most common diagnosis here will be an osteofibrous dysplasia, which is circumferential and is thickening of the proximal tibia. Like Sir said, if it is an osteoma, it will be only in one cortex and it will have thickening only in one cortex. I mean, it won't be circumferential, like he said. So here, I think the diagnosis here is osteofibrous dysplasia of the tibia, which is a common condition. It will be mostly sclerotic like this.
Whatever it is, at the end of the day, the PG is what has to say as far as this patient is concerned. Osteomyelitis, because osteoblastoma is not a clinical diagnosis per se. So osteomyelitis, to start with, you can say it's an osteomyelitis. Then after you can elicit this kind of discussion after seeing the MRI and CT. Okay, very well presented. Okay, thank you.
With this, we end the short case session. I request Professor Pasuri sir to honor the faculty. Professor Gopinath Menon, sir. Thank you, sir. Dr. Chokalingam, sir. Thank you, sir. Professor Arun Mani Rajan, sir. Thank you, sir. We'll be going to the long case skip discussion. I invite the next group of chairpersons. Professor Singer, sir. IoT happily welcomes you back, sir. Thank you, sir. Professor Thomas, sir. Professor Trinarayan, sir. Professor Srinivasan, sir.
Summer. Good morning, sir. My name is Vibha. I'm a final year postgraduate from Madras Medical College. Patient Summer, a 13-year-old male child studying in 8th standard from Bihar, presented with chief complaints of pain in the right groin and difficulty in walking since 2 years. History of presenting illness. Patient was apparently healthy until 2 years ago when he developed pain in the right groin. This pain was insidious in onset, dull aching in nature, gradually progressed in severity over 2 years, and was aggravated on lying on the right side and relieved on taking rest and medications. Patient during the onset of pain had a episode of fever, which was low grade and intermittent, and had repeated fever spells over the subsequent 2 years, which was self-relieving. Patient had complaints of difficulty in walking, which progressively worsened over 2 years. Initially, patient was able to walk, run, take part in sporting activities, climb up and down the stairs without support, squat and sit cross-legged. But after onset of symptoms, patient is currently only able to walk up to 500 meters and climb up and down climb a few stairs up and down with a railing support. Is able to squat for a few minutes and is not able to sit cross-legged. Patient is not able to take part in sporting activities the way he used to prior to symptoms. Patient also has complaints of loss of weight and loss of appetite. There is no history of trauma prior to symptoms. No history of early morning stiffness. No history of pain in any other joint. No history of no history of abnormal bleeding or repeated blood transfusions, no history of skin lesions, no history of burning micturition, redness of eyes, or watering of eyes, no history of altered bowel habits. Past history.
History of loss of weight and loss of appetite apart from fever, which is there. So is it significant? Because everyone will say that there will be history of loss of weight and appetite. Is it significant or?
So there's losing of clothes, but not able to quantify it since the patient's attention.
So he is the informant. And who is that? His mother is there?
Father.
Okay, right.
Treatment history.
Yeah.
Treatment history, patient was taken to a local hospital in Bihar for his symptoms and was managed conservatively for his complaints. Past history, there is no significant comorbidity, no surgical history or no prolonged treatment in the hospital. Personal history, there is no contact with passive smoking, no contact with other known cases of tuberculosis. Birth history, patient was born to a non-consanguineous marriage, has 2 siblings. There are no similar complaints in any members of the family. Prenatal, natal, and postnatal history have no significant history. Developmental history, all gross motor, fine motor, language, and social milestones were attained at a normal age. Patient has no behavioral problems and scholastic aptitude is normal. Immunization history, patient is immunized up to age.
Why do you ask passive smoking?
So could be a precipitating factor of Perthes.
Perthes, is it?
No, sir, 2 years back.
2 years ago. Oh, okay, okay.
He's 13 now, sir, so 11 years.
So problem started only at 11 years of age. I thought it started 2 years of age.
11 years of age.
And is there anything else you asked?
Sir,
Painless limp.
sir,
History of any painless limp. Was it noticed when he was, around
No, sir.
7, 8
Patient
years?
was normal before.
Till 11 years, he was absolutely normal.
Yes.
No. So from
Exactly.
history, probably etiology you want to, narrow down on what are the possible etiologies?
So my differential diagnosis would be infective, post-infective sequelae, and developmental. Any developmental diseases.
Yeah.
Example.
Most likely you want to think in terms of infective pathology of the right hip, non articular problem.
Even Perthes at around 9 years of age is a good thought to entertain.
11.
9 to 11 months, you can get bleed Perthes. Yeah.
Okay, so these are the two problems you think.
Yeah, now it's worsening. It's worsening now.
The limp is worsening, sir. Pain is it's dilating and persistent throughout.
You think it's an active infection or a sequelae? You said sequelae.
Sir, could be a post-infective sequelae as well. Not sure until.
So when was the last episode of fever? Because he has never had any prolonged treatment for infection, correct?
Yes.
So he never had any significant cough or hemoptysis or anything, right? So when was the last episode of fever?
2 months back.
2 months back. How long does it last?
Low-grade fever, which
Low
is
grade.
self-limiting on
Self-limiting.
taking medications.
But when the problem started, did he have fever?
Yes, sir.
He had at that time. Oh, yes. But was it very prolonged?
No, sir.
At that time?
Self-limiting.
Even that also was self-limiting.
So every time he used to have fever, and then in between period, he was absolutely normal for the past 2 years, or he was having pain on walking.
He was having pain on walking, sir.
He was having pain since the time of onset.
Yes.
He was having even in between that, but the aggravation happened
Yes,
when there was.
he has rest pain and night
Actually, you did not elaborate anything about the pain.
Yeah, the rest pain and
rest
night
pain
craze,
and night.
it was there.
Yes.
Rest pain and night craze. Both are there.
So how do you describe the night craze? What did he say?
So patient goes to sleep and then his father said that he wakes up 2 to 3 hours later with pain, and then they have to give him medications, and then he.
A classical cyst.
Yes.
So how long this has been there?
2 years.
2 years.
Yes.
Every day almost?
No, not night cries occasionally, so not every day.
Okay.
Rest pain and night craze coexisting. What probable condition you think? You think it is possible?
So what did you mean by rest pain?
So pain at rest, which is.
No. Pain at rest means the pain is always there, you said, constant. So even at rest, the pain is there.
Yes, sir.
So that is the meaning you think that it is rest pain? Or anything else? So what do you actually understand by rest pain? So is it
You
what?
not ask properly about rest
Yeah.
pain, sir.
So this
it's
is
not really possible.
Yeah. So what condition, as Professor Tilmaran was telling, what condition do you think if it is rest pain is there?
Infective or malignancy.
No, which condition has classical rest pain? For
When
which
you mean rest pain, you are hovering around one probable diagnosis
like
that you want to
pain
say
which
later.
relieves with the NSAIDs, osteoid previous case. When you want to say about rest pain, which condition you are thinking?
Not at this age group.
Just a common question, not for this boy. When do you classically ask?
Inflammations.
Inflammatory, right? So anyone? Commonest condition for which you ask rest pain?
This AVN.
So
Okay,
AVN is
last.
avascular necrosis is one which we commonly ask for rest pain. So the patient has pain when the patient is taking rest, and as the patient starts walking, then the pain gradually goes off. So it may be there in the inflammatory condition, other things are also. But the classical condition for which we ask is avascular necrosis. So this boy having pain at rest, it means that the pain is continuous, even present during rest. So that is how we should describe. night cries is very significant because the way you describe the history, how much significance you are giving and what is the message you want to give to the examiner. That is what we are looking at. So this history, it will be very beautifully well elicited and everything you have included. This history, what we understand is 2 years pain and limp in the right lower limb associated with fever, low-grade fever, and it is progressively worsening. The pain, there are history of night cries.
Yes.
Correct?
Yes.
Okay. Okay.
On
Yeah.
Examination, sir. On general physical examination, patient's height is adequate for age. He's thinly built. There's no pallor, icterus, cyanosis, clubbing, or edema. There's a lymphadenopathy of the cervical upper jugular lymph nodes. There's a single solitary swelling.
Single lymph node
Yes.
on the right. Right. Yeah, you continue.
A single lymph node swelling which is firm on palpation, non-tender, mobile, and it's not warm.
The insignificant. Okay. Yes.
Other systemic examination is normal. I checked chest expansion during respiratory system examination. That is also regional examination on standing. Patient's head and neck are in the center. Bilateral shoulder and scapula are at the same level. There is no scoliotic curves in the spine. There's exaggerated lumbar lordosis. Both on stand. Bilateral anterior superior iliac spine are at the same level. The attitude of the right lower limb, the hip is extended, knee is extended with patella facing forward, and foot is plantigrade. On the left side, there is mild flexion of the hip and knee, and foot is plantigrade.
Mild flexion.
Due to shortening on the right side.
No, you are now describing as the patient is standing. Standing, it is enough. That's the head, neck, and shoulder, spine, scoliosis, kyphosis, lordosis, if you want to maintain, and then the plantigrade fit. Right.
Examination and sitting, there is a shortening of the thigh segment on the right side. Examination in supine. There is no exaggerated lumbar lordosis. Both the anterior superior iliac spine appear to be at the same level.
No, you can just tell about attitude, deformity, muscle wasting, limb length discrepancy before you come to the examination specific of the right upper hip.
Hip is extended. Knee is extended with the patella facing upwards, and the foot and ankle are at a position of ease.
Can you come? Just come to this side and see the position of the feet.
So it's less external rotated.
The most important. That's what we are looking at. Okay, so right lower limb is less externally rotated when compared to the left lower limb. Okay.
There's a visible shortening of the right lower limb and muscle wasting in the gluteal, in the thigh and calf compartments. On examination of the right hip joint proper.
What about deformities? Are there any
No corona, such thing.
No deformity. No flexion deformity also.
Yes. I'll come to it.
What else deformities before?
There are no fixed deformities.
No fixed deformities. No FFD also.
Sure, there's no FFD.
Even I was doing, you'll have to pick it up on the exam when you're doing,
But you have already committed. So the case sheet, difficult, but at least now you should say it. Right. Okay.
Okay, right.
you said exaggerated lumbar lordosis.
Standing.
One lying down.
You don't see for exaggerated lumbar lordosis. You lie down on a hard couch. You lie down on a hard couch to see exaggerated lumbar lordosis. Okay, that is only confirmatory. So there was obvious exaggerated lumbar lordosis. So it's easy for you to comment on FFD, no?
Yes, there is expression.
Okay, examination, you continue.
On inspection of right hip joint, there is no fullness or swelling in the Scarpa's triangle. No visible pulsations. Inguinal orifices are normal. no dilated vein scars or sinuses. Laterally, the greater trochanter seems to be more prominent and more superior compared to the opposite side. No dilated vein scars or sinuses. And posteriorly, there's both posterior superior iliac spines are at the same level. There is gluteal muscle wasting. Gluteal folds appear symmetrical. On palpation, medially there's no swelling or fullness. On palpation, both the anterior superior iliac spines are at the same level. There's an exaggerated lumbar lordosis. Anterior joint tenderness is present. There's no warmth. Laterally, the greater trochanter appears thickened. There's no broadening or irregularity, and it seems to be more proximally migrated compared to the opposite side. Posteriorly, there's no palpable mass.
Trochanter, you have to say about pertrochanteric and bitrochanteric tenderness.
Yeah, there's no pertrochanteric tenderness. Bitrochanteric tenderness is positive. Posteriorly, there's no palpable mass. There's no tenderness in the posterior superior iliac spine. Ober's point tenderness is present. Immediately, no significant palpable findings. Deformities, there's a fixed flexion deformity of the right leg.
Around 20 degrees.
Um,
Any other fixed deformity?
no coronal plane
Okay.
rotation.
Other
Movements.
Commit on whatever moments you had when you did exam, you tell about the moments.
In the coronal plane, on the normal side, abduction was up to 60 degrees. And at the 60. Yes, sir.
60 degrees.
Abduction, yes.
Normal side.
Normal
Oh,
side.
okay. No, tell about abnormal side. That is it.
On the abnormal side, abduction is restricted to 25 degrees, sir. Adduction is up to 30 degrees. Flexion is up to 120 degrees. Yes,
Now you want to start where it started flexion?
20 degrees of fixed flexion deformity to
That-
120 degrees.
Yeah, it's always nice to say the range because then it will tell the examiner that you are aware of the deformity also.
So 20 to 120.
Yes, sir.
See, you have to be very careful in telling movements because you have to tell from 20 to 120 whether the available range of movement is painful or painless, whether it is associated with crepitus and
Yes.
spasm, whether there was an axis deviation. If you follow these 5-6 points in movements, because your diagnosis is mostly on, based on your movements. You have to be very careful. I'll probably repeat, all the points, whether it was painful, whether it was crepitus, spasm, whether there was axis deviation.
Movements were pain-free, sir, terminally restricted due to muscle spasm. There was no associated crepitus. Rotations with the patient supine and hip and knee extended. Internal rotation is up to 45 degrees. External rotation is restricted to 15 degrees, sir.
Show the rotations. So demonstrate the rotation. No. Okay, you want to say an extension.
Yes, sir. Hip and knee and extension.
You said how much internal rotation? See, pelvis is tilting.
So, what's
See.
the other way of doing it?
With the patient prone and knee.
That's a better way.
Can I just confirm that?
Up.
Like,
Yes, it.
you know, I don't know when to find.
Yes, sir.
Then ask him put tilt and prone. No, first. What about external rotation?
Yes.
Yeah.
It's restricted.
Keep it very relaxed. You know how much external rotation is.
It's 45.
Oh. Okay.
Internal is not so much.
See? So let's start.
Yeah. So when you're in doubt, put the patient prone. Okay, put the patient prone for the patient.
Yes.
The internal rotation is 15 degrees.
Vastly restricted.
Yeah, and external rotation is slightly it is more.
Do it in prone.
Electron.
No, exactly opposite.
No, she didn't say, but she said that almost internal rotation is normal.
Your internal
Ah.
patient.
Go for internal.
See, it looks like almost it is, there is a fixed external rotation.
Yeah, so around 15, 20.
See? No, no, you.
Then
Pelvis shorting. Can you see?
So if you don't hold it strongly, then the pelvis can move and it can give you a comfort. So it is hardly around 10 degrees. Only this much. So he is a very thin boy, so that
Check the amount of external rotation. Relax, relax. The amount of external rotation. Still it's good. Yeah. Now it's holding it tight.
Yeah.
20, 30.
So around 30 and around this is 10.
And one more finding, sir. So one more finding I saw is there is exaggerated adduction. There is abduction is restricted, but
See the
relax, kunchu it is. Sir.
It's a little more than, maybe
More than
the normal.
Yes.
see that.
Going to pain. No, no, no. It is going the same.
Yeah, compared to the normal settings.
Some better closest thing. Oh, it's going there. You bring the adduction. Yeah, yeah. It's not adduction, but the adduction in the normal side is more. What degree? Other side is 5 degrees.
Less.
Yes, the restriction of adduction is little less, very less when compared. That I agree. Abduction is grossly restricted. Okay. So in extension, the internal rotation is 10 degree and external rotation is almost 45 degree. In flexion also, the internal rotation is around 10 to 15 degree and external rotation 45 degree. Okay.
There's no axis deviations. Measurements.
There's one movement which you should always do it in children especially is abduction and flexion. Okay.
So what is a gear stick sign? Okay, especially in this case, it is very useful. Inflection, abduction, inflection. You saw the abduction, it was restricted.
So that is the earliest sign
Keep inflection.
in the Pathis.
It is likely to be reduced in DDH. It is likely to be reduced in Perthes, etc. So if you do an abduction and flexion, that's one of the earliest findings that you are likely to get in these two conditions, right? So important for a child especially.
Apparent length, there's a limblin discrepancy of 2 centimeters with shortening on the right side. True length.
Between apparent and true, do you expect any difference?
Sir, I didn't examine it with the same amount of flexion. So can I?
Is it necessary to examine?
No, this pelvis is squared.
So even if there is 20-30 degree of flexion, we don't exactly, because as long as the pelvis, if the patient is lying in the couch like this, it is enough if you examine like this, because both the points, the pelvis is going to be the same. Only the adduction abduction is changing. Okay.
There's a true and apparent shortening of 2 centimeters on the right side, confined to the thigh segment. On Bryant's triangle measurement, there's a supratrochanteric shortening of 2 centimeters. The shoemaker's line converges inferior and to the left of the umbilicus, and the Chinese parallelogram converges to the affected side.
So only if the flexion he is not able to compensate, when it is obvious, then you have to keep the other limb also in the same degree of flexion, and then you have to measure. Then the apparent and true are different. Otherwise, the pelvic tilt is the same, even if there is a flexion deformity. If there is 20 degree, the amount of pelvic tilt is the same. The lordosis is same for both lower limbs. Okay, so there need not be any confusion.
Morrison's bitrochanteric distance is increased on the right side. So,
Increase.
Increased. What is the reason?
could be due to a lateral subluxation or the trochanter is more proximal and more prominent. So that's-
Okay, then we'll come to the X-ray and see that whether it is there, but if it is not there, then you'll have slight problem. Okay,